Warm welcome to all of you. Good evening, esteemed faculty. Today we are having a case of oral cancer. I warmly welcome our senior faculties today, Professor Rajiv Sakai sir, our own senior faculty, Professor Krith Parma, and we have very eminent oncology team joining today. Professor C.S. Mani, very eminent head and neck oncologist. Welcome, sir. Dr. Subbiya, the postgraduate from Valley. Professor Mayank Tripathi from Tata Memorial at Varanasi. Professor Ibrahim from ESI Valley, and Vinit Kumar sir is from LTMMC and at Sion. So we warmly welcome all of you. Dr. Supaya is kindly been permitted to present a case by Professor Pabita ma'am at Government Valley Medical College. He will be sharing a case on oral cancer. So warm welcome to all of you. Faculty, kindly take over. Good luck, Dr. Subaya. All the best. You can start.
Yes, sir. Thank you, sir. Good evening, sir. I'm going to present a case of carcinoma buccal mucosa under the guidance of Dr. B.M. Babita Devi, Professor and HOD, Department of General Surgery, Tirunelveli Medical College. I'm a third year postgraduate in Tirunelveli Medical College. A 69-year-old female from Tirunelveli, homemaker, belonging to low socioeconomic status, came with chief complaints of ulcer in the inner aspect of right cheek for 2 months. History of presenting illness. The patient was apparently normal 2 months back, after which she noticed ulcer in the inner aspect of right cheek, which is insidious in onset, gradually progressed to attain current size. History of excessive salivation, history of betel nut and tobacco chewing present, history of halitosis present, history of difficulty in opening mouth, no history of bleeding from ulcer, no history of pain over the ulcer, no history of inability to protrude the tongue, no history of difficulty in swallowing, no history of difficulty in chewing, no history of recent loosening of tooth, no history of trauma from sharp tooth or dentures, no history of chronic cough, evening rise of temperature, no history of hemoptysis, pruritic chest pain, no history of loss of weight, no history of loss of appetite. Past history, no history of previous ulceration, whitish or reddish patch in tongue, no history of tooth extraction from sharp tooth, no history of sexually transmitted disease. Comorbid history. Patient is a known case of hypothyroidism on tablet thyroxine 100 mg OD. Not a known case of diabetic mellitus, hypertension, TB, bronchial asthma, epilepsy, CAD, and CVA. Personal history. Patient takes mixed diet. History of betel nut and tobacco chewing for 35 years. Menstrual history. Attained menopause 20 years back. Summary. A 69-year-old female who is betel nut chewer presented with chief complaints of swelling and ulcer over the right side of the inner swelling of the right side of neck and ulcer over the inner aspect of right cheek with history of difficulty in opening mouth and excessive salivation and halitosis.
Dr. Subaya, good evening. Dr.
Yes,
Sahai here. Let's go to your first slide. The first slide on your history.
Yes, sir.
Yeah. Before that.
Sir?
Yeah. So this lady had was apparently 2 months back. You can tell us the size.
Sir, not
noticed. Can you hear me now?
Size is 3.5. Yes, sir. 3.5 class 2 centimeters, sir.
Right. So you can tell us that what was the size when she noticed initially and what is the size now? Okay.
Sir, patient presented initially with the ulcer over the inner aspect of right cheek only, sir. We clinically noticed the swelling over the right side of the neck, sir.
No. The size of the ulcer also the patient can tell that what was the size of the.
No, sir.
No. Yeah.
The patient complains only ulcer over the inner aspect of right cheek only, sir.
Exactly. So what was the size when she noticed it first? Has it increased in size?
No, sir. Initially, small spectral like ulcer.
So say that.
Small size. She told.
So you have to say that she noticed maybe half a centimeter size discoloration. You have to tell us what was the size when she noticed first and what is the size now. Right. Second, you say
initially
that history of excessive salivation.
Yes, sir.
Now, is that important? Betel nut chewing is much more important, isn't it? How does excessive salivation help you in this place? It comes much lower down. Detailed showing is much more important, isn't it?
Okay, sir. Okay, sir. Okay, sir.
Yeah. So that should move up. Now, what was the sequence? Did she she has you write history of difficulty in opening of mouth. Since when? After how
Yes,
many
sir.
days
Okay,
after
sir.
noticing the ulcer did you get this problem? Is it progressing in size?
Okay, okay, sir.
Is the difficulty, is the opening of mouth decreasing? That tells us whether the disease is progressive or not,
Yes, sir.
right?
This is initially ulcer, followed by difficulty in opening mouth, sir, followed by patient develops excessive salivation. That's the
Exactly.
order, sir.
Now, no, what I'm trying to understand, want you to understand, is that
Yes, sir.
is the mouth opening decreasing as the time is going, as the time progresses?
No, sir. Initial same presentation will be from initial ulceration now to patient come to presentation same like difficulty in opening mouth. No decrease in size.
Right. Dr. Subaya, when did
Yes,
she
sir.
notice difficulty in opening of mouth? Since how long?
After 1 month, after 1 month of ulceration, he noticed the difficulty in
Okay,
opening mouth.
after a month. Now, when you're examining her after a month, has it become worse?
Yes, sir. Worst.
So you have to say that, no? That is
Yes, sir.
progressing. That's what I'm trying
Yes,
to
sir.
tell you.
Yes, sir.
You have to establish whether the disease is progressing or not.
Progressive, sir.
Yeah, so you have to come. Okay. Did she complain of any other swellings, any other discoloration in the mouth,
No, sir.
any tooth problem at all, ever?
Yes, sir. Patient didn't history about didn't tell anything about tooth problems, sir. On
Did you ask?
examination,
Did you ask?
yes, sir. I asked her, sir.
Let's
In
see where you
examination, there
written.
is a sharp
No, no,
tooth
no.
only present.
Dr. Subaya, I'm not talking to you
Yes, sir.
about examination. I'm talking
Okay,
to
sir.
you about history. Show me
Okay, sir.
your next slide, whether they've
Okay, sir.
written any tooth problem or not.
Okay, sir.
Next slide. No, in the past, she's 60 years. You mean to say she's got all 32 intact?
Sir?
You mean to say that she's got all her 32 teeth intact?
Yes, sir. Patient all tooth is
She
intact,
got
sir. Dental
all
caries
32
only
intact.
present.
All 32 intact. Never had any this, because I've seen your PPT. There is loss of tooth in the picture. There's no loss of tooth.
Yes, sir.
No, yes sir means what? Is there a loss of tooth or
Yes,
no
sir. No,
loss of
sir.
tooth?
Sir, please show the clinical
No loss
picture.
of no loss of no loss of tooth, sir.
Yeah.
Okay. We'll come to that later then.
One moment, last show the clinical picture.
No loss of
Go
tooth,
to the
sir.
clinical picture slide, Subaya.
Okay. So we'll come to that later also. We'll discuss. I accept this thing. Okay.
So yeah,
About
just to intervene, is it okay to intervene?
yes.
Dr. Subaya, the question is,
Yes,
in
sir.
this lady, can you
Yes,
hear
sir.
me?
Okay. Yeah, able, sir. Yes, sir.
Can you hear me, right? Okay. So if you had difficulty in opening the mouth and
Okay, sir.
then got this ulcer,
Okay,
is
sir.
one scenario. You get this ulcer
Okay, sir.
and then get the difficulty in opening your mouth is the next scenario.
Okay, sir.
Okay, what do you think is the difference we're trying to get at?
Sir, if ulcer first initially present as a complaint, it may be a carcinoma involving the retropremolar trigone or pterygoid muscle, sir. If difficulty in opening mouth, initially anything is dental abscess something or pleuritic ulcer after ulcer, syphilitic ulcer like something.
See, you can have a lot of people complaining about difficulty in opening mouth without an ulcer. Have you heard of that or seen that? Have you seen that?
Yes, sir. One patient with dental abscess only, peritonsillar abscess patient is presented with difficulty in opening mouths.
Yeah, but that is very odd situation. What is a more common situation for which, what is the condition called when you have difficulty in opening your mouth? What is the name of the condition?
Trismus, sir.
Trismus, very good. So
Yes.
do you have anything to grade the trismus, how severe it is?
Yes, sir. This
What
is
is
the
it?
distance between inter-incisors are distance, sir.
Mm.
If we allow 3 fingers means it is a grade 1, sir. If we
Mm.
allows only 2 fingers, only grade 2, sir. Less than
Mm.
2 fingers, grade 3, sir.
Very good, very good. So
Yes,
let us say this lady
yes,
has
sir.
grade 2 or grade 3 trismus to begin with,
Okay,
and
sir.
then the last 2 months she came with an ulcer
Yes, sir.
in that same place. What
Yes, sir.
would that condition be?
The condition will be progressing to next stage, sir.
What is that? What is the reason why she had difficulty in opening beforehand?
Maybe tumor involving the deeper structure, loco-regional advancement disease.
So she never had an ulcer
Okay, sir.
before.
Okay,
She
sir.
only had difficulty in mouth opening, which you called as trismus,
Yes,
and you
sir.
correctly graded it. I'm telling you, it is grade 2 trismus she had for the last 2 years,
Yes, sir.
and she has this ulcer in the last 2 months.
Yes, sir.
This is different from she had
Yes.
normal mouth opening until she developed this ulcer 2 months ago, and then now she has difficulty in opening the mouth for the last 1 month. You
Sir,
understand the
patient.
sequence?
Yes, sir.
Do you understand the sequence?
Yes, sir. Yes, sir.
Okay, so have you heard any conditions which are related to fibrosis in the mouth?
Submucosal fibrosis.
You heard about it, right? So
Yes,
is
sir.
that a common condition?
It's a pre-malignant lesion for oral cancers.
Not a pre-malignant lesion. We can call it a pre-malignant condition.
Pre-malignant conditions. Okay.
They're different, two different things. So you can have somebody with trismus
Yes,
due
sir.
to a submucous fibrosis,
Okay,
which
sir.
later on can progress into or transform into a cancer.
Okay,
So
sir.
that is one scenario that your other examiners was trying to elicit from you. Whereas
Okay,
you
sir.
can have another cancer, similarly like what you're presenting, and
Yes.
which is also heading towards a trismus. You can have
Okay.
two people, one with trismus and one without trismus in the last 2 months duration.
Yes, sir.
So what does it imply now? When you first have the ulcer and then develop the trismus, we are looking
Yes.
at cancer spreading to
Okay, sir.
the structures which open the mouth. What are the structures which open your mouth?
Muscles of mastication, sir. And the masseter muscle, pterygoid muscles, temporomandibular joint.
Very good. So in this situation, the location where the ulcer she is complaining, which is the muscle which will be involved?
Sir, masseter muscles.
Masseter, very good. So that's the right answer.
Yes.
So if you have masseteric muscle involvement, this lady is going to complain of opening difficulty in opening the mouth. Correct. So
Yes.
indirectly, you're telling us that this ulcer has deepened to the extent
Yes,
where it is involving the masseter in order to cause this trismus. That is the pathobiology you're trying to convey to us. All right. So I'm going to consider this as a very, what should I say, very fast growing cancer. All right. And your other exam is also asking you about tooth, whether if the tooth is becoming looser. So what does that mean?
Yes, sir.
What does it imply?
Sir,
Whether the
patient
tooth is
initially
getting,
in history-wise patient no complaints of loosening of tooth.
Very
sir.
good. Suppose, let us say she did complain of loosening of the tooth. What is the meaning to that?
Yes, sir.
What does it mean?
So maybe involvement of mandible, sir, through that loosening of tooth.
Very good. So you see that the tumor can extend from the inner side of your cheek, which is buccal mucosa. It is going to next involve the what is known as the sulcus, the bucco-gingival sulcus.
Yes.
Yeah, so you have gingivobuccal sulcus above, you have gingivobuccal sulcus below, isn't it?
Yes.
So depending upon which tooth is loose, you want to know that whether if the disease is extending into that sulcus, upper or lower, and then whether it is infiltrating the tooth sockets to make the tooth loosen. So that is what we are trying to ask. Or contrarily, you can have a very poor hygiene in a lady
Yes, sir.
with
Yes, sir.
halitosis, and just the poor hygiene itself is sufficient to cause loosened tooth. So we need to, if she complained she had a loosened tooth, we need to figure out whether it is a part of her hygiene or is it due to the disease. So that is what we have to decipher. So unless you have this reasoning in your head, you don't know what to go and
Yes, sir.
examine there. Okay. So now
Okay, sir. Okay, sir.
we are talking about this lady having this ulcer and causing the trismus with nothing affecting her tooth. I am going to imagine that this disease has not affected the any of the tooth sockets above or below, and it
Yes,
is
sir.
only deeply burrowing into the masseter muscle
Masseter muscle.
for which she
Yes.
is giving it. So my concern now would be how far it has involved the masseter muscle, whether if the skin is intact and all that.
Yes, sir.
But my concern
Okay, sir.
about the bone involvement will be less.
Okay, sir.
You get the point?
Yes, sir.
All right. So now you tell us about your examination findings to corroborate or to discount what your history says.
Subhaya, before going to the
Yes, sir.
examination, just a word and the summary. So, can you go to the summary
sir.
slide? Yeah.
Yes, sir.
In the summary, you mentioned about the neck swelling also, but you have not mentioned about in the history. Can you just elaborate on that? You summarized, but you have not
Yes,
mentioned
sir.
anything about the neck swelling in the history wise.
Yes, sir.
Can you just elaborate? It started before the ulcer or after the ulcer? Where is what
After
is the
the
location?
ulcer, only patient developed the swelling, sir.
Okay.
After the ulcer, patient only noticed the swelling over the right side of cheeks, right side of the submandibular regions.
No. Submandibular regions and all will not be mentioned by the patient, no? Can you just tell
Sir,
how
right side of neck,
how
sir.
she
Right side
told?
of neck.
No, why you have not mentioned it in the personal or the history of presenting illness?
Yes, yes. Sorry.
No, it got missed. That's all right.
Yes, sir. Got missed.
Got missed. Okay. So what else you want to tell? The timing. Then what are the if there is any swelling? What are the additional histories you will get for any neck swelling?
Sir, any reason is evening rise of temperature to rule out TB, sir.
Okay. Painful or painless swelling?
Painless, sir.
Waxing and waning?
No, sir. Same size only, sir. From initial stage, same size only. Patient
Okay,
noticed
so
the swelling is same size only, sir. He noticed before come to hospital only. She noticed, sir. Initially ulcer only she noticed. Then he noticed. Does he notice the swelling, sir? From relatives on told about there is a swelling over the right side of neck. So patient come to the complaints the hospital with the complaints of ulcer and swelling over the neck, sir.
So by the history, we can come to conclusion that a local disease is becoming locally advanced
Involving
disease
the
now. It has
yes, sir.
started involving the neck. So that's the idea you are
Yes, sir.
giving through your history, right?
Yes, sir.
Okay. Please go ahead. Yeah.
Yes. General examination, patient comes oriented, ECOG. One, no pallor, no icterus, no cyanosis, no pedal edema, no clubbing, no generalized lymphadenopathy, hydration adequate, halitosis present, vitals 78 per minute, regular rhythm, normal volume, felt equal in both upper limb, palpebral vessels, blood pressure 130-80 millimeter mercury, respiratory rate 18 per minute, afebrile. On local examination of the oral cavity. On inspection, lips normal, nicotine pigmentation, and ulcer proliferative growth of size 3.5 cars and 2 centimeter in the right side of buccal mucosa, extending
Slide,
anteriorly
doctor.
about 5 centimeter from.
Yeah.
Yes, sir.
Now it's in. Yeah.
Extending
Go ahead.
anteriorly about 5 centimeter from ankle of mouth, posteriorly up to the level of retromolar trigon, superiorly about 1 centimeter from upper gingivobuccal sulcus, inferiorly up to lower gingivobuccal sulcus, irregular in shape, ill-defined margin, edge everted, no active bleeding, mouth opening restricted, dental caries present over the second premolar of upper jaw, sharp tooth present in lower second molar. Tongue and alveolus normal. Floor of mouth appears normal. Hard and soft palate normal. Uvula in midline. No tonsillar enlargement. Posterior pharyngeal wall is normal. On palpation, inspective findings of site size and extent are confirmed. Tenderness present over the arsal margin. Induration is present at the base of the ulcer. Doesn't bleed on touch. No mandibular thickening and irregularities on bidigital palpation. Examination of neck notes a swelling of size 2.5 cross 2 centimeter in the right submandibular region. Skin over the swelling normal, no sinus, no discharge, no dilated veins, not tender, mobile, and firm consistency. Some specific examination, CVS is CNS nuclear neurological deficit per abdomen.
I think we lost you, man. Can't hear you.
Yes, sir.
You okay?
Yes, sir.
So you're done?
Yes, sir.
All right. So summarize your positive clinical findings.
A case 69-year-old female presented with cheek complaints of ulcer over the inner aspect of right cheek. Over the right side of neck, 3.5 cross 2 centimeter. Sorry, is it audible, sir?
It's audible, but it's a little lagging. Doesn't matter. Carry on. So I can see the diagnosis slide. Is that your diagnosis?
Sir, my
says clinical stage of T2, N1, M0. Is that right?
yes, sir.
Okay. So can you explain to us what it means? Why is it T2?
Sir, tumor size is less than 4 centimeters, sir. 3.5 cross 2 centimeters, sir.
Okay.
And
now let's stay there. Stay there on T status. You're
yes,
saying
sir.
it is T2.
Yes, sir.
But you haven't. Did you tell me how much is the mouth opening in this lady?
It's a grade 2, sir.
No. What is the size? You should tell it in millimeters when you're talking about
yes,
physical examination.
Up to 30 millimeters, sir.
What is the opening here? It is 30 millimeters for her.
It's a grade 2, sir.
Give me the size and number, man. I will do the grading myself. What is the amount of mouth opening? Is it 20 millimeter, 30? You don't put your finger there. You have to get a scale and tell me in exact millimeters. Okay, that's very important.
Okay, sir.
You can't shove your finger in everybody's mouth and figure out how much they can open. Okay, you may have a very good fingering technique, but I don't accept that as a physical examination finding. Okay. Change of a millimeter matters a lot for this lady, so you should be conscientious about that. Okay. So physical examination means you have a scale in your pocket and measure the interferences at distance, not shove your fingers all over the place. Okay.
Okay, sir.
Now, I agree that there is maybe 30 millimeters, like you say, which is not a great deal. How do you explain the T2 then? See, you said there was difficulty in opening the mouth. Okay.
Yes, sir. Yes, sir.
So if it is only T2, How do you explain the difficulty in opening a mouth?
No, sir. It's a T2 means no adjacent structure involved. In difficulty in opening mouth, maybe it involves masseter muscle means T4A, sir.
You're giving T2. I mean,
Yes,
I'm
sir.
going with your
So
clinical
clinically, the
history.
patient. Yes.
So what is that in the clinical examination you're missing? You gave me a dimension.
Yes, sir.
Right? What is the dimension you've given me?
3.5 cross 2 centimeters, sir.
Okay. What is the dimension which is missing?
Depth missing.
Depth is missing, right?
Yes, yes, sir.
So when you don't have a depth, you
Yes.
can't so easily do the staging like this. All
Okay.
right.
Okay,
So
sir.
why didn't you clinically assess? See, 33 centimeters is sufficient for you to do a bidigital examination of the buccal mucosa.
Okay,
Why
sir.
don't you give me a guess of the thickness of the lesion?
So it will be 0.5 to 1 centimeters depth.
So I'm going to take it as 1 centimeter, right? So if you take it as 1 centimeter, which is 10 millimeter,
1 centimeter. Okay, sir.
what's that?
Yes, sir.
So 1 centimeter would mean 10 millimeters.
Yes,
Okay.
sir.
So 10 millimeters would still make it from the depth of invasion point of view as T2.
Yes, sir.
All right.
No, sir.
Noah, do you know what is depth of invasion?
Sir, from basement membrane to infiltration areas.
Correct. So if it is 10 millimeter, what is the stage?
Sir, T2, sir.
So still it doesn't explain the difficulty in mouth opening,
Yes, sir.
isn't it?
Yes, sir.
So how do you explain that? Your diagnosis, clinical history,
It's wrong.
and the physical examination do not match.
Okay, sir.
So which means you have to put a question mark. You're not sure,
Yes, sir.
and you want to check it out with some further radiological investigations before you can give a stage.
Okay,
So
sir.
clinical staging in the TNM includes radiological as well. Okay. Anything you
Okay, sir.
do pre-operatively, initially, radiological also is part of the clinical staging. So you say that this is
Okay,
what
sir.
you can define by your physical examination, but you would like to get radiological investigations to confirm.
Yes, sir.
All right. So let us argue that do you have a scan picture or something for this lady?
Yes, sir. Yes, sir. I have, sir.
Okay. Get that picture.
Sir, slide didn't move.
Not moving, yeah?
Yes, sir.
Okay, you tell me the finding.
The ill-defined heterogeneous enhancing, since we did a CECT neck, sir, in which ill-defined heterogeneous.
How did you do the TT of the mouth? What is the classical thing when you do for imaging the buccal mucosa? Can you hear me?
Sir?
You can hear me now? Did you get the question?
The ideal CECT neck, sir.
Now, for the mouth, how do you get a proper imaging?
Yes, sir.
What is the instruction you'll give your radiologist for the best imaging?
The CECT neck, sir.
Neck will only show the neck, man. If you ask for neck, they're going to show you the neck. We have to assess the involvement in the buccal mucosa, and you're wanting to know whether if masseter is involved or not. If
So
you ask for
to masseter
CECT
involvement,
neck, they will tell you about
only bone involvement, mandible like thing, sir.
What will
For
you
muscle,
ask to the patient? What will you ask to the patient to do while they do the CT scan? Is there any specific maneuver, sir, is asking, which you instruct the patient to do while they do the imaging?
no, sir.
So, have you heard of something called puffing up?
No, sir.
What is it? You have not heard of that?
Yes, sir. No, not yet, sir.
Not heard?
Yes.
Okay, so suppose doctor asks for a puffed cheek view. Have you heard of this?
Yes, sir. Like
You want to demonstrate and show? I can see your face nicely. So that is called puff cheek. Why do you do
okay,
that? What is the difference between doing a CT scan normally and doing a CT scan with a puffed cheek? Any difference is there? What happens to your cheek when you puff your cheek?
Sir, our soft tissues will become lateral. Bone window will become more prominent, more easily visible in puffed cheeks.
Okay. So, and also what else will you decipher? What will happen to the air in the CT scan?
Black in color, black, sir.
Give you a good contrast to measure the depth.
Yes, sir. Yes, sir.
It will also tell you whether if the mouth opening is good or not. I mean, if the tissues are infiltrated or not. Can it tell you that?
Yes, sir.
So you don't ask for just a CT neck, you ask for a CT of the oral cavity with a puff
Okay, sir.
cheek view and
Okay, sir.
include the neck. Okay.
Okay, sir.
All right. So did they say about the you can see it is a puff cheek view. Can you tell me whether it's a puff cheek view or a normal view in this case?
Sir, puff cheek view, sir. There is a air in the region.
What is that region called?
There is a air inside the.
What is that region? That air region, what is it called?
Buccal mucosa, that soft tissue.
The
Vestibular, sir.
sulcus, man.
Gingival sulcus.
So when you puff your cheek, the gingival sulcus will get blown out, huh? And you can see this. Hearing you or someone else. Okay. So that is the view that you have done, and you have done that without knowing the terminology of what you have asked for. Done, is it?
Okay, sir.
Okay. All right. So you can see how the tissues change when you puff the cheek. Okay. All right. So what do you show in this image? What are you showing this image?
Sir, mandibular infiltration is there, sir.
Okay.
Then there is a node, submandibular node. That's
Talk about the lesion.
the lesion involving the right buccal mucosa.
What is the extent? Where is the masseter muscle in this cut?
Yes, sir.
Where is the muscle?
Yes, sir.
Show the muscle, man.
Yes, sir.
That the one? Can you take, do you have only one section or do you have more sections?
So I have one section, sir.
Okay, so roughly the place where you showed is where the masseter should be. All right.
Yes, sir. Yes, sir.
All right, so let us agree. Can you tell me, name all the other structures you can see in this scan? What are the other structures you can see?
Mandible.
Very good. What are the parts of the mandible seen?
Body, ramus.
Good. And what else is seen?
Condylar.
Where is condyle? There's no condyle here.
No condyles.
Sorry? This section doesn't show the condyle. So what are the other structures you can see here?
So pterygoid plate will be null.
Where will you see the pterygoid plate? This is, we are seeing the mandible. We are not seeing the maxilla, no? Maxilla, the pterygoid plate is in the maxilla or is in the mandible?
Maxilla.
Then why are you talking about that in mandibular section?
Sorry.
What other things are you seeing? What are the round and white structures you're seeing? What is that thing in the back of the section? What is the show? What are the round structures?
All things are
Sorry?
the base of the skull, sir.
There's no base of skull there, man. That's still mouth only. You see gingivobuccal sulcus, and where will the base of skull come? That's all in your imagination. There's only one section we are seeing that is showing your teeth. Your teeth and the patient's teeth is only seen here. So where will you go for the skull base here? Isn't it? There's no skull base here. You're showing the ramus of the mandible, body of the mandible, all right. So the round structures are the carotid artery and the internal jugular vein.
Okay, sir.
You understand? And they are very critical structures to see to decide on operability.
Okay, sir.
Right.
T4B,
And
T4B,
then you're
sir.
Array. Did I ask you anything now? I'm asking about normal structures. Why are you talking all nonsense now?
Okay, sir.
Right. So we are seeing that the carotid and the jugular vein are looking normal. You can see the vertebra and the cervical vertebra is looking normal. Your base tongue is looking normal. So all the lesion is confined to the buccal mucosa and involving the GB sulcus on the posterior extent and involving the bone on the right side. The last molar tooth is probably involved by the disease. Okay. Where did this suddenly 4B come from? What is 4B?
It's engagement of carotid artery, pterygopalatine plate involvement.
There's nothing there, no?
Yes, sir. No, sir. That
don't get flustered, man. You're seeing the disease right in front of your eyes, and I'm showing you that they're all looking normal. Why would you suddenly jump to say 4B? You started with T2 and suddenly you become 4B. So what is the CT scan? How does it upstage the staging so far?
So far, it's a T4A, sir.
Okay, so there is bone involvement. So we can say it is T4A.
Yes.
That's all there is. All right. And I'm not very clear about the masseteric involvement, although it is very close. That is where the masseteric muscle is there. We need to see further sections to confirm on that. And even if it is involving masseter, still it is going to be only 4A. All right.
Yes, sir.
Okay, what does the next slide show? Okay. Don't change, man. We have one more section in that CT, no?
Sir.
What is this? What is
in this section?
show?
We see the neck node, sir.
Why it's not? I'm telling you it's a submandibular gland. I'm telling you it's a submandibular gland. How do you prove me wrong?
Sir, node will be round in shape, sir.
What is their cystic inconsistency? So how do you explain that? I'm telling that a saliva-filled salivary gland. Why do you consider that as a node? So what are the features you should see in a node?
The round in shape, cystic in nature, and longitudinally.
Saying one slice and you're talking about longitudinal. See, all that is an ultrasound finding. See, the problem is if you come already fixed in your head, you'll go on repeating like a parrot, whatever it's fixed in your head. You're not seeming to understand that you have to describe something which is shown here. And none of what, is there any longitudinal axis shown here?
No,
there's only one axial section you're showing me. How will I know about the longitudinal distance?
No.
Okay. So based on one slice, what are the features we are seeing? I agree with you. There is cystic component there. What else is seen there?
There is a no necrosis, no necrotic materials.
Dr. Subbiah, relax. Okay. I know it's difficult to interpret this time, but a cystic, what you think a cystic may be actually necrotic node. Understand? So in a CT, it is tough to make out that. A necrotic node. So I would consider this as a necrotic node.
Okay, sir.
You can see some of the cortex which is intact and parts of the node which is necrotic, giving the illusion that's a cystic node.
Okay, sir.
Okay.
Okay, sir.
If there is no solid elements, that is no cortex and is fully filled with the fluid and entirely cystic, it can also be, okay, for example, you can have a lesion which is HPV positive lesion that can give rise to a purely cystic metastasis, which is known. But this is not showing that. This is showing a lot of cortical material is there. You have to see the cortex and the medulla in a lymph node. And you should see what are the things that have been altered in that.
Okay, sir.
And what you see here is you do see bits and pieces of the cortex with a lot of necrotic material in a well encapsulated lesion. Is there any extranodal disease in this?
Mandible only involvement, sir. Bone involvement will be there, sir.
I'm asking you in this picture.
No, sir.
Does the node's capsule is intact or it is breached? You can see the capsule all around intact, right?
Intact, sir.
Correct. So that means
no extranodal extensions.
Okay.
Yes, sir.
All right.
Yes,
Okay,
sir.
go to the next slide. Now, what is the restaged disease? How did you change the staging now? Tell me.
Is the N1, sir. Size will be 2.5.
Sorry, I'm not able to follow you. Can't hear you well. There, are you lost? Hello? Hello?
I think, sir, we lost his connection. We just call him.
E4A N2M0.
Yeah, just switch off your video, Dr. Suven. Just hello.
Also, yeah. Can't hear Subbiah. Subbiah, are you there?
Yes, sir.
Yeah, just switch off your video, Dr. Subbiah. Dr. Subbiah, just switch off your video, please. Then you will be able to hear you well. Just switch off your video.
Yes, sir.
Go ahead. Yeah. Now, can you hear me well? So what is the staging
Yes,
after doing the CT scan?
The T4A N1 M0, sir.
Okay. All right. So you confirmed with your FNAC and the wedge biopsy, is it? Is that it?
Yes, sir.
Okay. So what did you aspirate when you put the needle in the
Yes, sir.
node? What did you see when you put the needle inside that node?
Sir, it's a hemorrhagic material will be
Did
seen,
you see
sir.
in this case?
Hemorrhagic aspirate only seen, sir.
When you aspirated, you saw some hemorrhagic material.
Yes,
How
sir.
much material did you draw?
There is a hemorrhagic aspirate, sir. Yes, sir.
How much material did you
About
aspirate?
1.1 to 0.2 ml, sir, only I aspirate, sir.
I see. So there is not enough fluid coming out from that cystic node.
So
is it?
about 0.5 to 0. Yes, sir. So not that much amount comes, sir. Only I aspirate amount, sir.
Lost, man.
It's about
Sorry, I can't hear you.
0.5 ml only aspirate, sir.
Okay, fine. That is fine. So you know how to how do you handle this material? If you aspirate 0.5 ml, what do you do with that? Have you done this procedure? I think you're lost, man.
Hello, sir.
I'm not able to hear you at all. So
Yes,
I think there is some connectivity issue. So I don't think we should carry on when I'm not able to hear you. Sir, are you okay to continue this?
So, Dr. Subaya,
yes, sir.
just keep your video off, and
Okay,
is
sir.
your internet connection okay? Let's give it a try again, sir. Sir, Professor Mani, sorry about this. Could you, sir, please carry on, sir? We'll take
Yeah,
another try.
yeah, okay. So I was asking, you aspirated
Yes, sir.
5.5 ml of the hemorrhagic fluid from the node.
Okay,
So
sir.
do you know what you do with this? What do you do with that material from the syringe?
Sir, I will do sliding, sir, for FNAC if I aspirate, sliding, sir, to confirm the diagnosis, sir.
How do you do the slides, man?
In the 5.5 ml placed over the one class slide, then over that I will scrape it, then do a
Don't scrape it, you smear it. Huh? Use the word smear it.
smear it, sir. Smear it, then examine under the microscope, sir.
You just don't take that slide and put under the microscope, man. That's not how it's done. What do you do?
That's
Do you air dry that or do you put it in a preservator?
preservative, sir.
Do you? So what is the preservator and what is the container called?
Formalin, sir.
Hmm?
Then
Following you.
formalin, sir.
Cytology slides don't go in formalin, man. Who taught you this? What is formalin? Where do you use formalin?
For exercise specimens,
I think, sir, I think there is some difficulty. Yeah.
Formalin, sir.
Yeah, somebody says Coplin jar, not Coplin, that's fine. But Subhai, I can't hear you, so it may be difficult to continue like this, is my opinion. So can I ask
Yes, sir.
Sir Rajiv Sahai to take over?
Yes, sir. Okay, sir. Yes, sir. I am able to hear, sir.
But I'm not able to hear you, man. Your voice is not clear to me.
Dr. Subaya, try to speak slowly, right? So that sir can hear you clearly. Do you get me?
Yes, sir.
Yeah, now it's
speak
clear.
slowly.
Okay.
Yeah.
So
Okay, sir.
there is some gentleman who gave an answer saying it's Coplin's jar, which is correct. But what is the fluid that you use as preservative? It's not formalin. Okay. The formalin fixes
Okay,
a
sir.
tissue architecture. Okay. That is the role of the formalin. The formalin will precipitate all the protein. The cytoskeleton will be, somebody is
Okay,
saying
sir.
spirit. Friday night means not always spirit, man. Maybe
Okay, sir.
you can use spirits for other
Isopropyl
purposes.
alcohol, sir.
Okay, all right, you can use that. Yeah, that's a good one. So you can use that for preservative, or you can even air dry. There's no harm in just leaving it under the fan for it to dry up, and you can go and deal with it in the lab. Okay. And only your tissue that you take as a wedge tissue that you put inside formalin.
Okay, sir.
What is the
Yes, sir.
what type of formalin will you use? Is there a specific type of formalin you'll use, or you'll use any formalin?
Any formalin? No ideas.
Array, you're working in the theater and every day you're sending specimens. You should have some
Yes, sir.
idea. See, there is somebody who is giving you clue. 10% neutral buffered formalin. Okay, that's the right answer. Pritik, who is Pritik? Is a student or is a faculty?
Sir, I'm a resident, sir.
Oh, good, very good. Pritik is absolutely right. So what does this formalin do is to kind of precipitate the cytoskeleton, so the cells will not collapse, or not get decayed. Whereas in a smear where you're seeing only cytology, there is nothing like that which is required. Okay, so isopropyl alcohol is a good thing. Okay, or you can use even glutaraldehyde for all you know. Never mind. So you did that, and you think they're saying suggestive of squamous cell carcinoma. Do you want to believe them, or you don't want to believe them?
The oral cavity in buccal mucosa squamous cell carcinoma is the most common, sir.
I'm asking you from a FNAC of the submandibular swelling. They are saying it is squamous cell carcinoma. Do you want to believe, or you don't want to believe?
Believe, sir.
You want to believe. Tell me what the reasons why you want to believe this report.
Sir, patient clinically, I have a complaints of ulcer over the oral cavity, sir. And radiologically, there is a confirmation with a suggestive of malignancy. So it may be.
What are the features in the radiology that was confirmatory?
There is infiltration in the mandible.
Correct. Know what we are talking about? The node was not infiltrated to the mandible.
Sir, there is a primary lesion with secondary over the node, sir. So there is a.
You tell me there is a enlarged node with a necrotic center, and you can see some solid material with an intact capsule, all suggestive of a metastatic node.
Yes, sir.
So since all your clinical history, physical examination, radiological examination all add up together, then you say, I will believe this diagnosis of the cytologist.
Okay, sir. Okay, sir.
That's how you add up to things. All right. So you are saying there is wedge biopsy showing moderately differentiated squamous cell carcinoma.
Yes, sir.
So are you surprised, or are you not surprised by this?
So not surprised, sir.
Why? What will make you surprised?
So if other than squamous cell carcinoma, we may be surprised, sir. In oral cavity,
so what other things can be there in that place other than squamous cell carcinoma? What else can be there? Can you have adenocarcinoma there?
No, sir. It come from my gland, mucosal glands, maybe it adenocarcinoma, sir.
Correct. So you can have a minor salivary gland tumor, but the clinical features are not like this, isn't it? So you can have any other things other than. So is there anything in the specialized in the squamous cell carcinoma that you'd like to know? Because this lady is presenting within 2 months history, trismus. So there's something more going on than the routine and dumb moderately differentiate, isn't it?
Yes,
so
sir.
Can you tell me what are the variants in this which will behave more aggressively? Have you heard of something like that?
No, sir.
Where is Pritik? He's not answering in this.
Sir, I just to mention, like other variants of squamous cell carcinoma basically are the types that it presents. The verrucous type, there is a spindle cell modification. Sometimes it has an adenoid component. It could
Very
be
good. So we are
adenosquamous cell.
looking at from the moderately different. See, the diagnosis here is moderately differentiated. I'm asking you, is there a more aggressive variant than this to explain this patient's condition? Because less aggressive variant, we're not bothered. This patient is having trismus alongside the ulcer. So we are looking at more aggressive variant.
Poorly differentiated means it's aggressive, sir.
Very good, but this is moderately differentiated. Your pathologist knows what she is talking about, he or she is talking about,
Yes, sir.
isn't it? So what
Yes,
they
sir.
have not mentioned is whether if there is any special type in this. That's all they're not. And you should know what could be the special types that will behave more aggressively, okay? And Pratik was right in saying that component of verrucous, which is a low-grade tumor, that will not behave like that. But the higher grade tumors would be?
Yes, sir.
Any idea?
Aggressive.
Yeah, spindle cell variant, Pratik said, is a good answer. And you can have even better answers than that. Okay.
Yes, sir.
There's something called adenosquamous. There's something called papillary type. All these things can be much worse in its behavior. Okay. So you can have a larger area of moderately differentiated squamous cell carcinoma, whereas some areas could be behaving very differently. Okay. So that's the idea about this discussion. Okay. So what will you do next? You have 4 minutes. What will you do next?
Sir, it's a tumor with bone involvement and secondary metastatic to nodes, sir. So we managed with wide localization of primary tumor with segmental mandibulectomy with MRND, sir.
Very good. So how did you reconstruct?
Pectoralis major myocutaneous flap.
Doing pectoralis, why would you do segmental mandibulectomy? What are the types of mandibulectomy?
Marginal mandibulectomy, segmental mandibulectomy,
Your voice is dragging. Anyway, you're right. I could barely hear that. But you don't use marginal here because the bone is already involved.
Yes, sir.
But you can use segmental, but only if you are going to do a bone reconstruction. Here you are not doing a bone reconstruction, you're doing only a pectoralis flap. So I might as well do a hemimandibulectomy, right?
Yes, sir.
So what is the point of leaving behind that ramus hanging there when you are only doing a pectoralis major?
Sir,
sorry. I'm not hearing you, but anyway, you've done well and keep it up.
Go with the sir.
Okay. Any other faculty, sir? Hello. Hello.
Hello, sir.
Yeah. Anyone would? Dr. Subaya, are you there?
Yes, sir. Yes, sir.
Yeah. Hello. Dr. Ibrahim, sir. Hello. Dr. Tripathi. Hello.
I'm audible, sir.
Yeah, you're audible. I just calling other. Dr. Mayank Tripathi, are you there, sir? Dr. Vineet, sir? Okay. Dr. Subay, I think you've done very well. I can't seem to, I think,
yes, sir.
The participants. Dr. Vineet? Professor Vineet, are you there?
on this. Now these are the charts that.
Suvaya, what is commando's operation?
So,
The wide local excision of
Dr.
primary
Subaya?
tumor with hemimandibulectomy with MRD.
What does it stand? Commando. What is the full form of commando? No. It is COMMANDO.
Yes, sir.
Dr. Subaya, that's an acronym. Sir is asking what is the full form?
Full form.
Can you hear? Yeah.
Composite oral mandibular. Hello, sir. Composite.
Yes. It is combined mandibulectomy and neck radical dissection. Okay. Your voice is breaking.
Neck dissection operation, sir.
Now, what are the complications of the neck dissection? What are the complications of the neck dissection?
The bleeding, infections, injury to nerves, marginal mandibular nerve.
What are the various types of bleeding?
Spinal axis.
No. What are the various types of hemorrhage or bleeding?
Primary or reactionary.
What is primary? What is primary hemorrhage?
During surgery, within 6 hours. During surgery, there is a bleeding. It's primary bleeding.
Yes. Reactionary?
Reactionary within 24 hours. Sir.
Okay. And third type of hemorrhage is?
Secondary, sir.
When does that occur? Okay. 5 to 7 days. That is because of the?
In 24 to 48 hours.
No. In 24 to 48 hours, it is not secondary. It is 5 to 7 days or even later.
Okay, sorry, sir.
That is because of the infection.
Yes, sir. Okay, sir.
So one is hemorrhage. What are the other complications?
Injury to nerve, sir. Marginal mandibular nerve, spinal accessory nerve, lingual nerve, hypoglossal nerve.
Okay, so injury to any nerve may be there. Yes.
Carotid artery blowout, sir.
Yes. How can you prevent the carotid artery blowout? How can you prevent the carotid artery blowout? Are you there? Subaya, are you there?
Yes, sir.
Yeah.
Yes, sir. I'm there.
Yeah. Tell that. How do you prevent the carotid blowout? Why does it occur usually?
CT, MRI, angiography done, sir.
Sorry?
If tumor.
Okay, for prevention of the carotid blowout, you should make sure that the flap does not necrose at that point. Because whenever you're doing the neck dissection, there may be some angulations may be there which may be lying right at the carotid area.
Yes, sir.
So to prevent the flap necrosis at that point. Second thing,
sir.
you should not make it absolutely bare.
Okay, sir.
Okay, some tissue should be over that.
Okay, sir.
And then you can use certain muscle to cover that. Do you know which muscle can be used? Like in inguinal block dissection, you can use a sartorius muscle to take care of the femoral blowout.
Okay, sir.
Similarly, here
Okay,
which
sir.
muscle can be used?
Pectoralis major.
Pectoralis
Delta
minor.
pectoral flap. Okay.
No.
Majors.
Any local muscle which is there. In that
Delta
area.
pectoral flap for delta pectoral flap, sir.
It's the levator scapulae muscle.
Okay, sir.
Okay, levator scapulae muscle. That can be used to cover that
Okay.
area there. Okay, what
Okay, sir.
other problems can occur?
Recurrence, sir.
Recurrence, okay. Anything else? Which is there mainly on the left side, not on the right side? What is there on the left side, which is not there on the right side? You have to be careful on the left side.
Recurrent now, sir.
That is on both sides.
Arch of fight. Arch of fight was there.
Arch of aorta doesn't come in that. Does it come? The arch of aorta there? Anything you damage and the white color material comes out.
The chylothorax, that
Thoracic duct, no?
thoracic duct, sir.
Yeah. Oh, that is mainly on the left side, Jay.
Okay, sir.
What is the frozen shoulder after the neck dissection?
Nerve damage.
Yes. Which nerve will lead to the shoulder, frozen shoulder?
Accessory nerve, sir.
Yeah. What does the spinal accessory nerve supply?
Trapezius muscle, sir. Trapezius.
Trapezius and sternocleidomastoid.
Okay,
Okay, it supplies the two muscles, sternocleidomastoid and the trapezius.
okay. Okay, sir.
Now, how you are going to reconstruct after you have done?
Okay, sir.
How will you reconstruct that area in your case? Or tell what are the principles of reconstruction?
In my case, for bony reconstruction.
Bone reconstruction, yes. Then what else you have to reconstruct?
For bony reconstruction, that's a free fibular graft, sir. Free fibular graft, sir.
Okay. Okay.
Followed by pectoralis major.
Is it only the bone reconstruction you have to do, or you have to, once you have excised the skin, you have excised the lot of mucosa?
Yes, sir.
So what are the various things you have to reconstruct?
For that, pectoralis major myocutaneous flap used.
So you will require the skin, you will require the mucosa, and you require the support, the bony support.
Sir. Yes, sir.
So what are the various bones which can be used for mandibular reconstruction?
Fibula.
Yes. Fibula will be for a free flap, है ना?
Yes, sir.
Any local regional type of the thing which you can use for the reconstruction of the mandible?
Forearm radial flap, sir.
That is again a free flap.
No, sir.
Along with some pectoral muscles or the deltoid muscle, can you use some flaps there?
Delta pectoral humerus. Clavicle, sir.
Which bone you will use?
Humerus.
Humerus, no. Humerus doesn't come in that area. 。  No?
No
What is
idea,
the
sir.
lower
No
end of the
idea, sir.
neck? Which bone forms the lower end of the neck?
Clavicle, sir. Clavicle.
Clavicle. Yeah, so you can use the clavicle on the posterior side. Any bone?
Scapula.
Scapula can be used. Yes. Then you can use from the some bone from the skull. So all these bones can be used as a regional type of the flaps.
Okay.
How will you bring the skin in that area? What are the various flaps which can cover the skin?
For that, caltobacterial flap,
Okay.
pectoralis major myocutaneous flap,
Yes. Anything from the front of the head?
forehead, the frontalis.
The forehead flap can be used, you know. These are
Yes, sir.
various regional flaps which can be used for that.
Yes, sir.
Okay, Dr. Shah.
So thank you so much, sir. Okay, Dr. Subaya, you've done well. Sir, Dr. Ajay Khanna, Professor Khanna, sir. Sir,
Yeah.
hello. Sir, could you assess him? Could you give him some tips and advice of what was performed?
Actually, I was busy in another
Yes, sir.
seminar, jo hai na. There was
Okay,
the
sir.
AI seminar going on. I was busy in that, so I could not hear that. Yeah.
Okay.
But I think overall it did good. Yeah.
Okay, Dr. Subaya, I think you've done very well. Professor Mani gave a lot of insight into what is important is that you can't make you can't stage the disease without radiological investigation. Do you get me? Because depth of the lesion is very important to stage, right? And for oral cancer, staging is done. Radiological examination is a part of your clinical examination, and only then you should come in for staging. So you can say that clinically, I think this is my stage, but I will confirm it by radiological because depth of invasion is very important here, right? Similarly, for nodes, extra nodal extension is again very important.
Okay, sir.
Right? Yeah. So that was there.
Okay,
and
sir.
in your history you should have a clear-cut timeline. Like beetle chewing is much more important than any other of the features. So it should come right up, right?
Okay, sir.
Okay. Yeah. Okay. Thank you so much, everyone,
Okay,
for
sir.
taking out your time. We had a wonderful day. Thank you, Dr. Subaya.
Okay,
You've
sir.
done very well.
Thank
Good night,
you,
everyone.
sir. Thank you, sir.